Meeting to order. Slightly late, but I want y'all to know we've been on the job already. We started over on Sherwood Avenue at Virginia Children's Center at 8:30, and we treated that meeting as if it were just right next door, but it's actually about 15 minutes away. So it took us, we were a little bit over. So thank all of y'all for being here, and those of you that will be participating. Understand we do have one of our members on the phone. Anyone there?
Yes, Mr. Chairman. Yes, Mr. Chairman. It's Delegate Rush.
Hey, good to have you with us here. It would have been too rainy to drive in all the way from where you are today.
That's right.
Or is it raining down there?
Oh, yeah, it's raining.
Okay, good. I got the weather report. All right. Thank everyone. I think we won't introduce ourselves today. This is Work Group 1. We've got a busy day planned for all of SJR 47 group, and thank everyone for being here with us this morning. We will begin with a presentation, an update of the work of the System Structure and Finance Expert Advisory Panel. And who do we have here representing? Okay, Dr. Bonnie's back there. Didn't see him all the way back there. All righty.
Good morning, Mr. Chairman. It's a pleasure to see you.
Yes.
And a pleasure to be appearing before you to talk about the work of the System Structure and Finance Advisory Panel and the support work that's being provided by the Institute. I know you're running behind, and so I'm going to try to keep this part of our presentation fairly short. As you can tell from the schedule, we're going to be talking with you about the work of the panel and a couple of pieces of unfinished business on that. But immediately it's going to be followed by work, a report of work that the Institute is also supporting at the chairman's at Senator Deeds' request on the hospital bed crisis, and John Oliver, who's a consultant with the Institute, is going to be presenting on that, and I want to leave him ample time to update you on the work of that task force. So as for myself here, I want to, the two pieces of unfinished business relate essentially to questions that are now arising in the wake of the tremendous progress that the General Assembly has made and that the administration is strongly propelling forward. Taking note that we're essentially in the early stages of a transformative process. And there are a lot of moving parts in the process. And as we've been looking into this, there are a number of aspects of financing and oversight that we haven't really had to focus on in the past, that now, because of the ambition of what the General Assembly has done and what the administration is implementing, have come to the fore. So one of them relates to the funding formula, as we are calling it, and the allocation of funds by the department to the CSBs. Here's a perfect example of where the goal, the ambition of this present system is so much more substantial than the ambition of the Commonwealth beforehand, and indeed the very reason that the Joint Subcommittee was appointed. And now we have a vision and a commitment to providing a full array, a full continuum of mental health services across the Commonwealth in a consistent fashion that's accessible to everyone in need. And so therefore, the code provision before, as you know, basically obligated the CSBs to provide emergency services, and if funding was permitted, essentially the other services, including case management, which was singled out. And now, obviously, the ambition is to have the full array of services and to implement STEP Virginia. And even though we're in the early stages of that effort, it was pretty clear that what has been the practice with regard to allocation of the state general funds wasn't going to fit the ambition of STEP Virginia, which was now a comprehensive access plan for all the services envisioned in STEP Virginia. And so the general practice, if I understand it, and you'll hear more from Kevin Farrelly after I make this introductory comment, essentially had been basically building on the, from year to year, on what the CSBs had been receiving. And then there were, in various years, pilot projects that the General Assembly had authorized or funded, and then there was competition for the grants. But now, when the goal obviously is statewide access in all the CSB catchment areas, it begins to look like, other situations where the General Assembly and the Commonwealth have accepted the responsibility to provide statewide access to services. So as we began to think about it, it became clear that it was certainly beyond our expertise to come up with appropriate formula, and that there were other models that exist in the state, and that probably the right way to go would be for y'all to think about requesting a study by JLARC or another body with the appropriate expertise. And so we've been thinking about how to draft a resolution for you with regard to what that study might entail. So we've talked with you about that briefly before and have given it more thought in light of the conversation that we then had. So Kevin is going to just go over the key elements of the resolution that we're going to be suggesting to you, which is one of the handouts. The second thing we want to talk about is the role of regional management and oversight in the newly developing system. And this is in direct response to questions that members, the chairman and the other members of the joint subcommittee raised the last time we were meeting. And so we've gone back and done a little research in response to the questions that had been raised. And there we have a several-page report for you about that. And Kevin will also go over that. I think one thing I'd like to say, well, maybe I'll just stop at that point and have him come up and talk to you about the first of these items, and then I'll resume the podium and introduce the second one.
Okay. Very good. All right. Thank you. Kevin, good morning.
Good morning. Thank you. As Professor Bonney mentioned, we looked at ways that a future study might look at the ways that large portions of state funding are given out to CSBs. So CSBs receive state funding in a variety of ways, sometimes through RFPs for targeted funding allocations for targeted projects. But large portions of that state allocation are given out through the performance contract on a largely maintenance of effort basis. So that is looking at what level of funding they've received in previous years, going back and looking at marginal, whether the CSBs have demonstrated a need to increase or decrease marginally from year to year, but characteristics like demographics, Medicaid penetration, income, and the ability of localities in a CSB's catchment area are not explicitly taken into account when those monies are given out. So we are proposing that a JLARC or a similar body look at whether incorporating those elements into how funds are distributed would have a positive impact and be a more efficient way to distribute those funds. We are also in here recommending that consideration be given to whether this should only apply to new funds to avoid there being large winners and losers or large disruption should there be a change in the way funding is given out. So you could envision if it was recommended that the department incorporate these factors in the future, that when large amounts of funding that are going to be given out to all 40 CSBs, that if it's new funding on top of current levels, that these factors are taken into account.
I just want to ask a question. Given we had information this past year that JLARC would conduct shorter studies, and we talked about coming up with a way to provide funding to CSBs like we do, analogous to our school funding formula. Would that require us to actually have a resolution, or just my understanding was we could just ask JLARC to make a short study, and that they could do that within a couple of months under their new model.
Yes. I spoke briefly with some of the JLARC staff, and while the process for requesting these shorter turnaround studies isn't totally ironed out yet, we're waiting for maybe a little bit more information. My understanding is that you could request a study. We would need to be fairly specific in what it is you're looking for, what you want addressed, and the factors involved. We could communicate that to JLARC, and it would go through the JLARC committee, and they could undertake the study without having to do a resolution. So
Without having to do a resolution.
without a resolution, and they could undertake it during probably the session in the spring this year before they get busy with the other work that they do.
So then, Mr. Chair, then I suggest we take what Kevin's factors into consideration. We come up with a specific request, and we make it to JLARC as soon as possible so we can get that work undertaken.
I would agree with that, and Senator Barker?
Well, just to jump in a little bit on this issue, at the HHR Oversight Subcommittee, the joint subcommittee that's been set up that has 4 senators and 4 delegates, which actually includes Senator Hanger, Senator Howell, and myself, Delegate Garrett, and a couple others, from the House. I think we do have the opportunity to be able to move in this direction here and do some of these types of things. They're still sort of working through the process. They presented to the Oversight Subcommittee in terms of how they would like to have us interact with them. But I think that now is the time to start that process and move forward on it.
Right. And what we could do, and I agree, Senator Deeds and Kevin, I think a combination here that I would share with you, Senator Deeds, of wanting to be aggressive and maybe becoming a little bit impatient in terms of how quickly we want to move down the road with this. It appears to me that we created just this past year and stood up this special unit of JLARC just for this type of thing, and it's being ironed out, and we're hoping we'll continue to iron out in a way that it won't be complicated and won't be time consuming. So it would seem to me if the work that you all have done, we could get that together. Maybe you all at the table with representatives from Senate Finance and House Appropriations staff from this commission, and decide what kind of information is relevant that we need to gather. That might be the longest part of it. Once all the information is gathered, it seems like the group could sit around the table and come up with some recommendations fairly quickly. But I would concur with that.
That, Mr. Chair, I think that's fine. The reality is, the last few years we've made significant advancements in mental health funding in Virginia, some things that we've never seen before. But when we put together STEP Virginia, we knew that it was going to have a price tag in excess of $200 million a year. And we've got to come up with a realistic formula. It upsets me to think that we could have STEP Virginia but not a robust array of services all over Virginia. So we need to come up with a recommendation. We need to come up with a request for JLARC to come up with a study of how we provide sufficient funding throughout the state of Virginia, to all 40 CSPs.
Thank you, Mr. Chairman. If I could just add to what Senator Deeds just said, I like the open, robust funding rather than tying it, as was referenced earlier in this presentation, to how we do schools. Because as I've been thinking about this, there are so many models out there that the CSBs are really the outlier. You can go all the way from the progress we made in maintenance of our roads, when it used to be an allocation to each residency, irrespective of need. And then we went into a state of good repair and real analyzing where the needs were. You can look at what we do way back when in our community colleges, where technically, like the CSBs, we have specific 23 campuses. And yet, whenever the need grew, I said campuses, but I meant to say community college, we started multiple campuses. In our school funding formula itself, it's about, first and foremost, the number of children that are sitting in classrooms, so that the outlier that we have this artificial delivery of services, something that we tried to deal with, whether it was state or local or what combination there is, into 43 components. I just wanted to add this to say that JLARC takes all of its background in how we allocate funds to apply, rather than just looking at the elements of the school funding formula, which some tend to look more at the cost to compete and issues of that nature.
Mr. Chair,
Senator Dees?
I'm not suggesting that we use the elements of the school funding formula, but I think that the school funding formula is designed to look at ability to pay.
Yes,
And not to penalize localities that pay more, but not to disincentivize that, but to make sure there's some basic structure that addresses ability to pay. And that's all I'm talking about. I'm not talking about using the sales tax and the real estate values or whatever, but.
Okay.
Mr. Chairman.
Yes. Gary.
So, thank you, Mr. Chairman. Kevin, the verbiage that I have here in front of me, the JLARC or another organization with the necessary expertise be requested to conduct a long-term, in-depth study of the current method of distributing state funds to CSBs and to examine alternatives that would reduce unnecessary variations in levels of funding across the CSB system. So for 4.5 years, we've been working to try to understand what those variabilities are, and that's kind of what I thought we were charging you all to do. And it strikes me we're now asking a different body to do that rather than this body, which was established by the General Assembly, to in fact exactly do this, number one. And number two, it strikes me that if you ask any of the CSBs what same-day access means, you're still going to get 40 different answers. If you ask any of them what emergency whatever means, you're going to get 40 different answers. So with all due respect, Mr. Chairman, I think asking JLARC or anybody else to figure out how we can do state-level funding for all the 40 CSBs without them understanding and have data and the substructure that shows what the CSBs do and how they are different already is a fool's errand, frankly. It's very frustrating to me to say, well, let's just go ask JLARC to do another study of what we've been studying for 4.5, almost 5 years. 2 years ago, I had this conversation with Professor Bonney. We need to know what the variabilities already are with the CSBs. And we've done a lot of great things, as Senator Deans has just said. I absolutely agree with that. And I'm not on JLARC. If they want to do a study, I got no problem with that. But it strikes me that asking them to do a study of something that is pretty elusive right now and not well defined is rather problematic if we actually want to get something pragmatically done.
Maybe we misstated a bit what the charge is. With regard to the information about the current funding and the funding streams, that work has been done, and we've submitted it to the Joint Subcommittee, both with regard to the sources of funds from the CSBs, including the state general funds, as well as all the other sources of funds that they have, and we've presented that a number of times. In addition, the variations in the services that are actually being provided, which of course is the underpinning, for the advances that are going to be made under STEP Virginia. So that's the first. So we don't need them to do that. That information is available, all of it. The most important thing in terms of the things that you've said, which we do not know, is that we have to do with what the demands are to build the capacity that STEP Virginia envisions, right? We are just in the very beginning, as you know, of trying to build the capacity for the CSBs to provide the services for same-day access, for primary care screening, and for outpatient services, and then eventually, all the other ones that are there. And that, I think, is the challenge that the department faces, that the Secretariat faces, and that the General Assembly faces, will face on a continuing basis, because we're trying to put this in place when we haven't actually, we're putting data systems in place that will help us identify what the capacity, the capacity that the systems have, and then the demand, both on the supply side and the demand side of this. And that information is going to have to be, I'm sure that the department and the Secretariat are working on that, as we speak. But As that happens, and that does have to happen, and that's not what JLARC needs to do, I don't think. I think what needs to be done is, as all that is happening, we need to have some kind of a framework or formula or approach for allocating the state general funds in accord with what a moving target with regard to what the CSBs are going to need to carry out STEP Virginia on a continuing basis. I think that's what the challenge is, because otherwise the department, I think, and it would be helpful, I think, if the department and the Secretariat have guidance from JLARC or some other body acting at the instance of the Joint Subcommittee, because, as was said, we have multiple models out there to be used. What we do know is that the model we now have does not fit the ambition of STEP Virginia and of the Joint Subcommittee. So that's what needs to be done. It's not to find out what the funding streams now are. I'm sorry, the words suggested that. It's to think about what we do going forward with this highly complicated, set of funding streams that are going to be involved in building the new system that we're trying to build. And we're at the very beginning. And putting a data system in place is the only way that we're going to do it, as we did discuss a couple of years ago, that the SPQM as well as the DLA 20 is going to help soon to begin to put that data together about what the services are that are accessed and what their outcomes are. And what the CSBs have the capacity to do. So what we want is for the General Assembly to help put in place something to actually help implement what the vision that you've set forth. So I think that's the where we are right now with this.
Dr. Garrett? Just as a follow-up, so let me ask the question a different way, Professor Bonney. To create JLARC to do a long-term study to look at state-level funding for what? Because that's the problem, Dr. Bonney. I'm not convinced at all that we, the General Assembly, or we, the people, have a unified vision of what the what is that we're asking to pay for. We're just saying, let's put in more funding for same-day access. What does that mean? Because my sense, as I've gotten around and talked to the CSBs, is that means something different at each one of those. For preventative issues, for emergency issues, there are different outcomes depending upon where folks live. Folks in Fairfax will get a different response than folks over on the Eastern Shore. And so I think we're going to need to better define what the what is that we're going to ask them to study, rather than just, if we had X amount of money, how much of it should go to CSB A versus Z.
Well, so let me recede at this point. I think you're obviously right. There need to be definitions of these things. My understanding is that the department and the Secretariat have been working on that, from the beginning. And I think, when you are speaking with them, you should find out kind of where that stands, because of course that needs to be done in terms of defining what we mean by these services. And then to be able to match what we mean by them with the capacities that the CSBs currently have, and then what is necessary to build.
Mr. Chair.
Thank you.
I think that's at least not the expert panel's job. Let me put it that way.
Well, Mr. Chair, I think Delegate Garrett is exactly right. We need to figure out how much money it's gonna take and how we're gonna divide it up. But the thing I think with JLARC's new structure, this is something we can probably get an answer to by the 1st of March.
Mr. Chair.
Senator Barr.
Yeah, just to pick up on this, I agree with Delegate Garrett here in terms of we have to have a clear understanding of what we're trying to accomplish here and what we need the funding for to be able to meet our expectations. And for same-day access, for example, does that mean that if I call up today, I'll get an assessment today, and if they decide I need treatment, it might be a month, it might be 2 months, it might be 3 months before I get my first visit because they don't have the capacity provided earlier? Or does it mean that as soon as they do that assessment and they determine I need treatment, I start the treatment then? And those types of things that we need to be able to measure and to be able to cost out what we want and what we think we're willing to pay for to get this level of service there. And I think part of the critical issue and part of what we discussed in a lot of our meetings is that if we don't provide the services when people are ready to receive them, we miss out on an opportunity, and we're much more likely to have expensive crisis situations down the road. And so unless we're willing to make the commitment to provide the services, there are going to be significant implications. And I can tell you, I represent 3 different jurisdictions, all in Northern Virginia. But in terms of, particularly historically, if you had a mental health problem, you were treated very differently in one CSB than in another CSB in my own neck of the woods.
Yeah.
And we need to say, we want to have the expectation be comparable across the system.
Right.
And we also then need to determine how much of that cost should be borne by the state and how much, if any, we're saying the locality should contribute to that as well. I think, you know, I mean, at least with the school system, we have clear figures. Even if you're Lee County, you got to come up with 15% of the money for, you know, basic educational costs. Here, we have, transportation, we have, you know, different things. I mean, here we have a system whereby if you don't want to pay, you don't have to.
Right.
Even when you're required to pay 10%, 10% is actually zero as long as I say I don't want to pay.
Right. And we're going to change that, I think.
Mr. Chair, we have to change that. Sarah reminded me that at 2:30 in the full commission, we're going to have a more thorough
Okay.
presentation on that implementation of STEP Virginia. And hopefully that'll give us some information
That sounds good.
from which we can make our inquiry.
Right. Because we have provided some funding, particularly in the second year, to move on down that path, and I think we're well underway. It appears to me, Kevin, Dr. Bonney, that conceptually we're with you.
Yes.
It's just the, you know,
Yes.
on this piece, it all ties together. And the second piece actually is very relevant to what Senator Barker was talking about in terms of the regional control perhaps, or something that will cause us to have uniform expectations statewide and a system that delivers on that.
And if I might add just one other thought here, and we'll obviously pick it up a little bit this afternoon maybe. It seems to me we need to design the system for where we want to be, not necessarily say where we are now and assume that that's going to be fixed and then we're going to tweak it a little bit.
Right.
So I think we need to really have a vision so that we're not shortchanging people, an individual based upon where they live.
Right. Agreed. Okay. All right, so conceptually, I think, and we'll come back to action, but that was the study piece, which I view it more as a partnership with JLARC. JLARC would be at the table as opposed to a long-term study, something that we can pull together fairly quickly. And the second piece, as far as the regional, Kevin, you were addressing that?
So just
Or
one
Dr. Bonney?
prefatory comment on that. So I just want to put the regional, the inquiry that we've been making in the context of the current work that we had done and had presented to you before. So I think the assumption being made now is that the basic DBHDS CSB structure remains in place. And now the question is, within that structure, in the effort to enhance accountability based on the performance-based criteria and the data and so on, as is stated in the handout that you have, with monitoring, appropriate financial incentives, fiscal realignment, there are a lot of moving parts, I think, in readjusting the relationship between the state through DBHDS and the CSBs to enhance performance, quality assurance, and accountability for the system that you all were just discussing, that we're envisioning in the future. And again, reminding ourselves that we're in the very early stages with many moving parts of this kind of transition. So in that context, the question that was posed is, within that DBHDS CSB structure, is what role potentially could regional governance or regional administration, regional oversight, and perhaps at some stage, depending upon what happens as the system unfolds, there might be consolidation, obviously, of CSBs and so on. But in that overall framework, what role might the regions usefully play? And I think that was the question that many of you put to us. So based on that inquiry, we began to look around the country to see what we were able to find in terms of regional structures and to reflect on what might be useful in Virginia, given the differences between Virginia and other places. And so, Kevin, maybe you can share your ideas about that.
So part of the point of this document is both to inform you more clearly what the current regions do, what are their roles and functions. This came up briefly at the last meeting in Fairfax last month. And so we have laid that out for you. They primarily manage funding and programs related to state hospital utilization and manage programs that are high cost, low incidence, such as crisis stabilization units and the REACH program. There are also other, opportunities for strategic problem solving that arise because regions tend to have, the CSPs within the regions tend to have more in common than out of the region, so sometimes unique things come up that the regions are then able to respond to. And that kind of differs across the state. Then we tried to, not to recommend, an alternative governance model for regions, but just to give you a sense of what that would look like and whether, how to go about implementing that. So the closest example, or the most applicable example that we could find is in Georgia. There are 25 CSBs in Georgia, and they are broken out into 6 regions. In Virginia, you might think that we have a 2-tiered system in which DBHDS oversees the CSBs. In Georgia, there's more of a 3-tiered system where you have the state agency, regional field offices, and then the CSBs underneath. So the regional field offices are kind of intermediaries that provide oversight, technical support only to their assigned region. So that is something that you could apply to our system, though we do not assume necessarily that that would be a good idea or an idea that would add value without studying it further. That is just logistically how it would be laid out. So again, if you have any other questions, so the point again was to both lay out how it looks now and an example of an alternative model.
Okay.
Mr. Chairman?
Yes, Doug Garrett.
Kevin, are there metrics to determine in Georgia versus Virginia, so 2 different models?
Yeah.
Do you have metrics, or have y'all looked at metrics to determine whether Georgians are mentally healthier than Virginians with this system?
We have not. I can say that Georgia has a long list of performance measures and accountability metrics it uses, just as DBHDS does, and so they assess themselves based on those, but we haven't compared them apples to apples.
Mr. Chairman?
The system has detected that a minimum number of lines are connected to this conference. Do you want to continue your meeting? Press 1 to...
Yes.
So,
Doug Garrett.
Kevin, is that a big lift to try to, I don't know what those metrics are that you would be able to compare between the two and whether the data is apple and oranges, I get that, but is that a lot of, to try to get the answer to that question? By some metrics, are Georgians mentally healthier than Virginians, and we can somehow ascribe it to a different structure?
I think that can be difficult to do, but we can certainly look into it. It's just generally hard to objectively compare state to state, but we can certainly look at that.
Mr. Chair, I just wonder if there's something you can look at other than the quality of mental health care to determine whether they're getting more bang for their buck through that. If they're getting more accountability through a system of regional governance. And are there other states, or is Georgia the outlier out there?
I don't think Georgia's the outlier. It's just that their system as a whole looks more like Virginia than some of these other states. So there are other states that use regions to organize accountability or to organize service delivery.
Well, Mr. Chair, they have 25 CSBs. My understanding is they've got more population than we do. How are the 25 CSBs divided up?
Is similar to Virginia in that there's a mix of single county jurisdictions or single county CSBs and multi-jurisdictional CSBs. It's just all over time they developed in natural ways similar to they have in Virginia.
Okay. It would seem, if we're going to follow up on that, the cost implications and as well as the quality of service and and some of it would be subjective, but whether or not the more economically challenged areas of the state are able to receive the same level of services as the more affluent areas around Atlanta and what have you. But it would seem to be worth following up on, at least as one example. Maybe there are others, but the model itself, I think, is one that we should perhaps pursue. It just makes sense that if you want to have a system that's the same all over the Commonwealth, that you need to have some way of controlling that, and regional offices would seem to do that.
Well, as you pointed out, the panel discussed all this, and as you pointed out, there are obviously some trade-offs and some cost issues in terms of where the staffing that's providing the oversight is and how that affects the staffing both at the CSB level and at the department level. I think the last couple of sentences of the handout sort of give you at least the view that the expert panel had, which is there are so many moving parts here that it would probably be better to to sort of not make an a priori judgment about whether or not regional management, would be a good step to make. There are a lot of other things that the department is going to be doing to increase accountability, as I mentioned, earlier, including the performance contracts, which I take it that you're going to hear about tremendous improvements that might be made in the performance contracts, financial incentives, the monitoring of outcomes, remedial action for deficient performance. We said from the start that increasing oversight by the department is the key aspect in terms of promoting accountability for performance. And whether regional management for that is a good contribution, it seems to me to be something that can be determined as things evolve, rather than trying to plunk it down at the beginning. But that said, obviously it could potentially be useful. But that's basically what the expert panel concluded about this.
Okay. Any other questions from the committee? All right, it would seem that on the first point there, that conceptually at least, we are supportive of gathering the information and making so we can make an informed recommendation on the funding. And it would perhaps, if rather than voting specifically on this piece, if we were to take this and charge staff with tweaking it a bit, so that we could then have a document that basically reflects the conversation we just had.
Right. And Mr. Chair, one thing I would like to add, I think, to what has been talked about here so far, but certainly has been part of our discussion all along over the last several years, is there a minimum size in terms of population served by a CSB for achieving economies of scale and being able to have the quality and the breadth of services that you need? Part of my concern is that if you get to a very small population, it's going to be very difficult with the amount of money that you're operating with to be able to meet everybody's needs with the expertise, particularly in certain situations where you have, particular things that are going to be more common in a population that's much larger.
Right.
Mr.
Delegate.
And if I could add to Senator Barker's comments and also his comment about having 3 jurisdictions with 3 different CSBs, all in Northern Virginia at various performance levels, that I will speak on behalf of the oversight of the 5 regions, which would at least look at comparable conditions in each of these regions, making better weighting between what you're seeing in one part of Hampton Roads, what you might be seeing neighboring South Side. Same thing would be true because of the way our funding has gone, where we've tended to go on a unit basis. What is the comparability between those 3 jurisdictions that George represents, plus the other jurisdictions, all with comparable populations and challenges and so on, that this is where regional accountability might be very appropriate, rather than assuming accountability is just one size fits all throughout the entire Commonwealth.
Okay. Other comments? Okay. Well, thank you all very much for the presentation, and we'll continue to work in both of these areas. I don't think we're prepared on the second one to make any recommendations
Mr. Chair, on the first question, I would hope that staff would be able to consult with staff for the Senate Finance Committee and House Appropriations, draw on the question as specific as possible about funding. Okay?
Okay. Okay, that'd be good.
Thank you, Mr. Chairman, for allowing me to call in.
Yes. You still with us there, Dr. Rush?
Yes, sir.
Okay, good. Do you have a comment now?
I just appreciated the committee allowing me to call in and participate. It's going to be hard for me to get down to Richmond today, so thank you.
You bet. All right, thank you. Okay. All right. Dr.
All right,
Bonnie,
so we're going to go to the next item?
Yes,
Okay,
we're ready.
So John
we're ready.
Oliver is going to, who's been carrying the load on the TDO State Hospital study, is going to present to you on that. Okay. Got it. I hope.
Nick, do you have the materials in front of you down there?
He has, and then they've been distributed here.
Right.
Mr. Chairman, I'm online. I don't see a link for that.
Okay.
Let me check it out, the
Okay.
live stream.
Our staff's going to email it to you.
All right, great, thanks.
All right, John, go right ahead.
Good morning.
Good morning.
You should have two reports in regard to this endeavor. The first is a 50-page report that came from the series of regional meetings that was held throughout the Commonwealth from the spring to the fall of this year with each of the HPRs. And in Region 3, we broke it down into three meetings because of the size of that region. And operationally, they have sub-regions, and there are specific projects that proposals that have come out of those regional meetings that are attached as appendices to the report to try to address some of the issues involving the crisis and the census at the state hospitals. Second report is from, as a result of the statewide task force meeting. The statewide task force reviewed the report from the regions, reviewed research from the Institute, and held two meetings in August and October of this year. At this point, there is not a consensus in regard to a specific set of recommendations from the task force itself, but there are a number of key themes that have emerged and some general consensus around those and the importance of them, and those are reflected in the report. So in regard to the research and the information on the crisis, clearly we've got an ongoing problem with the state hospital census from TDOs, and this chart reflects it pretty graphically. This just looks at half a year, 2014 through 2018, and you'll see between 2015 and 2018, the rate of TDO admissions to state hospitals went 2.5 times higher. Now, the overall trends, this next graph shows in terms of TDOs through this process. Since 2014, we continue to have substantially more TDOs overall, both to public and private hospitals. But you'll note that from 2016 through 2017, there's been a stabilization of that and even a lowering of the overall number statewide. However, at the same time, when you look at the private voluntary hospitalizations, they continue to go up at an even higher trajectory. And so what we're seeing is there are fewer private hospital beds available, first of all, because they're being filled by more and more voluntary admissions. And so that is a key contributor to the crisis at this point. We don't have specific information on the nature and length of those hospitalizations, and we're hoping, talking with VHHA, to try to get some more specific information about that. But you can see that the demand for hospital care, crisis hospital care, is continuing to go up throughout the state. The other factor...
Mr. Chair? Mr. Chair?
Yes, Senator Barker?
Let me ask a question there.
Yes, sir.
On that chart that you were just showing.
Yes, sir.
The line for the voluntary hospitalizations, is that the total number of hospitalizations other than TDOs to the psychiatric hospitals or psychiatric units of general hospitals, or is it only emergency admissions?
Well, it's private psychiatric admissions.
So it's all private psychiatric admissions?
Right. Yes,
Okay.
sir. Yes, sir.
Mr. Chairman.
Okay. Yes.
Well, and that means that's a bed that's not available. So that, I think that's the...
Yes, Mr. Chair, but I mean, it's a bed not available, but it's a different,
Yes, sir.
it's a different issue other than the
Exactly,
TDOs or something done in lieu of a TDO.
Yes, sir.
Yeah.
When the call is made, the question is, have you got a bed? And if your psychiatric hospital is filled because of your voluntary admissions, the answer is no, we don't have a bed.
Okay.
And John,
That'll
thank
go
you.
well.
And
Garrett?
could you get us another level of data? What percentage of the primary voluntary hospitalizations for psychiatric crises and the civil TDOs that are ostensibly involuntary, what percentage of those in 14, 15, 16, and 17 were supported by or provided by private hospitals versus our state hospitals?
Well, the top line is our private hospital admissions, psychiatric hospital admissions. That's the rate of admission to private psychiatric care in the hospital.
I understand, Mr. Chairman. My inference of this is that there's a growing disparity between, so the top line, the private voluntary hospitalizations are psychiatric crises, and they've gone from about almost 23,000 to 28.5 or something like that over the last 3 years. And there's also, concurrent with that, there was a rate of rise that sort of paralleled that, and it's now fallen off with TDOs. My question is, where are the private hospitals stepping up to meet this greater need for psychiatric crisis admissions vis-a-vis the state mental hospitals? We keep, our data and our challenge is that we've got to somehow support state hospitals that are now at 98+% of utilization. And I'm trying to get my arms around what percentage of the private hospitals for this increase in need of psychiatric crisis hospitalization is being met by private hospitals.
Well, in terms of the TDOs, the actual number of beds provided by the private hospitals is going down. The numbers are decreasing in absolute numbers. So there are fewer private beds available for these TDO patients, which is what's driving the large increase in the number of folks ending up in state hospitals. There are other demands on the private hospitals as well. You may be aware of the ligature crisis. The Joint Commission is requiring high level of facility rehab to reduce the possibility of suicide. And that's causing the closure of some facilities. The third factor that is impacting everyone is workforce. And there are any number of occasions where a hospital might be licensed to have a certain number of psychiatric hospital beds, but they only have a percentage of them online because they don't have enough psychiatric coverage with staff. And so that is an issue. All those issues are affecting the number of private beds that are available.
John, I think I'll try to figure out my question. I'll send it to you offline because I'm not
Yes,
articulating
and
my question.
I don't immediately have all the data you're looking for, but the bottom line is we have fewer private beds available, and as a result, even though the CSBs are doing quite a job in terms of stabilizing the number of TDOs overall, the percentage of those TDOs that are going to the state has gone from less than 10% just a few years ago to 20–25% of the total.
You get more at it. You wanted to know how many of the TDOs that were of that 28,000 were TDOs? Is that?
I'll clarify my question.
Okay. Senator Barker?
Yeah, Mr. Chair, just to pick up on what Delegate Garrett is saying, in Northern Virginia in 2013, probably 2014 as well, the vast majority of TDOs were in private hospitals for the 5 CSBs in Northern Virginia. A few went to state hospitals, but not that many. Now it's almost 100, it's the vast majority are going to state hospitals and few are going to the private hospitals, which has clearly put pressure on the state hospitals, particularly since our state hospital is a relatively small one in Northern Virginia, even though we're 30% of the state population now. And there are empty beds available there are empty beds in aggregate in the private hospitals. So what we needed, I think what we need to understand is how can we impact that to make sure that people are getting the services. When Senator Deeds and Delegate Bell and I and a couple of others back in 2014 were working on the legislation, we knew there was a risk, but I don't think, I at least did not expect that we were going to see as radical a shift. And in Northern Virginia, at least between 2016 and 2017, we were pretty much like the state as a whole, pretty flat in terms of total TDOs, but there was still a huge shift from the private hospitals to the state hospitals in terms of where those people went. And I think that is something that we need to get a handle on, because it was not our intent in 2014 when we were working on the legislation to say we want the state hospital to be where every TDO goes.
Yes, sir. Understood. We don't have specific information from the private hospital system. There are discussions going on still with the HHA in terms of disclosure of information, and don't have information to confirm your statement that there are open beds. And that, I mean, that is the question. What the private hospitals report is that there are three different factors going on. First, their census is pretty high because they have all these voluntary admissions. The second, we'll talk about the second thing, is they do have a number of patients they've accepted that end up, because they have chronic conditions and there are very few community placements willing to take them, they end up in an acute care setting for months rather than days. And so there's a real issue with the adequacy of community placements available. This committee's made a big commitment to permanent supportive housing, but it continues to be an issue, and I'll be touching base on a recommendation from Region 2 in regard to housing up in Northern Virginia and the kind of care needed. And then the third factor is workforce. Fourth is licensure and having to shut down certain rooms and beds or even units because they don't meet the commission standards for ligature. And the final is the challenges presented by some of the individuals. There are certain groups that are particularly tough, and one are individuals with intellectual disability or developmental disability. Almost all of those end up going to the state hospital. They present high behavioral challenges. They're individuals with a history of aggression or who are actively aggressive. Those tend, in general, to be folks that are not accepted by the private hospitals. The third category, which is one of the most urgent, which is individuals with complex medical conditions. As a result of the placement of last resort requirement, if an individual has complex medical conditions along with their mental health crisis, they're under an ECO and the 8-hour period runs and there's not a placement, they go to a state facility, and the state facilities are saying, we're not equipped to care for these individuals. And so you have a situation in Northern Virginia Mental Health Institute, they have to use so many cars to take people off-site for treatment, for dialysis, for wound care, for a variety of specialty care, that they have to rent cars because they haven't got enough state cars. The concern is the actual care that these individuals are receiving. The feeling is that these are individuals who ought to be in a general hospital that has a psych unit, so there can either be a psych unit placement with medical coverage or medical placement with psych coverage. But everyone agrees these are very complex and difficult patients, but they pose a disproportionate burden on the state hospitals because it takes so many staff to care for them. So you have some special populations are placing particular demand and tend not to be the folks who end up at the private hospitals. And you've got the fact that the private hospitals in some situation, when they say they're full, they're actually full. They're getting the demand for hospital care is going up. And of course, there's an overall increase in involuntary care. I mean, we have not, by any measure, returned to the pre-2014 numbers in terms of overall TDOs.
Mr. Chair, well, just a couple of observations on that point. At least in Northern Virginia, we've had several projects for additional psychiatric beds in the private hospitals that have been approved and additional beds coming online. What we've also observed is that the occupancy rates of the units in the private hospitals are far lower than the occupancy rates in the state hospitals. And it is a night and day difference there. Whether that means a bed's available and what are the issues when you have fewer people in those beds than your licensed capacity and yet a bed is still not available, that's something that needs to be, ferreted out a little more comprehensively on things. But we need to make sure that the hospitals that were meeting these needs in 2013 and now aren't meeting those needs, what has changed that made them unable to meet the needs of the people that they were taking care of previously? And, you know, what you're talking about with people who are medically complex.
Yes,
I
sir.
mean, ironically, I mean, Northern Virginia Mental Health Institute is basically surrounded by parts of Fairfax Hospital, facilities for Fairfax Hospital. There should be a way to get coordination there, which there at least used to be, that those with the medical conditions, when a TDO came, were placed in a hospital that could take care of their other issues and not just the mental health issues that could be treated at Northern Virginia Mental Health Institute. And so you didn't have to go rent a number of cars to be able to transport people to a facility where they used to be going in these situations. So I think we need to look very carefully at this. And I would add one other issue to it. One of the other issues that I think is significant here is the reimbursement issue. You know, the health plan reimbursement for many mental health services is less than what it costs. And as long as that is the case, it may well drive some of the actions and decisions that people make in terms of being able to provide these services. And I think that's part of what we need to add to our list of things that we're looking at there.
I would note what you've heard from me. Well, in each of the regional meetings, there was private hospital representation, all but one. And what you've heard from me just now is what has been represented by the private hospitals as the circumstance that they're facing. And we do not have data at this point. There are still discussions about the sharing of information. So it may be the committee's determination about how to move that discussion to another level. That is, this is what I've got from these group meetings with both public and private providers around the state.
Mr. Chairman, I think I figured out my question.
Did you?
I think so.
Were you finished, Senator Barton? Okay,
Yes.
that was
Yes,
Gary.
thank you.
Okay.
Thank you, Mr. Chairman. Are all the civil TDOs admissions to state hospitals?
No, those are.
And I know that was rhetorical. And have there been any new hospital psychiatric beds allocated since 2014 through certificates of public need and so forth? That's the data that we need to get, John, because we're not comparing apples to oranges. If the argument is there's a lot more admissions to hospitals, private hospitals, because of other issues other than the issues that we're facing with TDOs, I get that. But if in fact during that 3-year time period, if there are more beds that are available, then that number is even more eye-popping, to Senator Barker's point. But if in fact the private hospitals are meeting some of that TDO need, that's really the essence of the data, I think, that I'm interested in. I'll get you some questions of what I think.
Right. Those are questions I can't answer.
Do you have the data to answer
so,
them?
no, the data from the private hospitals we do not have yet.
Okay. Thank you, Mr. Chairman.
And I would note, part of what the private hospitals would respond to in saying is, look, approximately 80% of all TDOs are managed today by private hospitals. The issue here is it used to be 90+%, and that loss going from what you've seen here, because we have fewer state hospitals and fewer beds, the increase has been dramatic for the state hospitals and created a crisis. But it's still the case that 80%, though, whether or not that's stabilized, we don't know, but approximately 80% of the TDOs are handled by private
Chair,
facilities.
you're seeing a decrease in the percentage of TDOs that private hospitals are taking, but now you're actually seeing a decrease in the real numbers of TDOs that the private hospitals are taking.
Okay.
So, well, I would say up until the data I have from staff at the Institute indicates that the actual numbers since about 2016 that private hospitals have accepted for TDOs has gone down. So it's both percentage and absolute numbers of private beds for TDOs has declined.
Okay.
All right.
So
we touched on the ligature issue, and in all the meetings, there is certainly consensus about the need to fully implement STEP Virginia, and there is support for that. And for the services involved, I would note, while I'm not in the middle of it, what was expressed to me by in each of the regions is that the effort with the department in using what Professor Bonney referred to, the DLA 20, daily living activities, using outcome measures. How are people doing? How healthy are they? Are you keeping them out of the hospital, as opposed to, are you doing service A, service B, service C, is the real point. And so you compensate your agency on the basis of that. And there is commitment to that, in part because the notion is for the state general funds that are used under the DLA 20, the CSBs and the regions can use their creativity to develop a set of services that meet the needs of the people in their community. The other concern that they expressed was that that's not currently the model under Medicaid managed care, that it's compensation for services, and there's a specific set of services set out. They're managed by MCOs now. Each CSB has to deal with 6 different MCOs, and it's an administrative burden that they don't get compensated for. And as was noted, the actual compensation rate is often less than the cost of providing the service. In addition, the MCOs, as an example, and this is what was noted to me, one of the requirements is that there be continued improvement in the individual and as a result of the services provided in the community, your day services or in-home, things of that sort. And if the person stabilizes, then they don't need the service anymore, so there's no compensation. It's removed, the service has to be discontinued, and a few weeks later, the person's in crisis again. And that's the big concern as well, is that the framework for compensation in terms of, these are people we're being successful with because we're maintaining their stability, and the money's being pulled out. We can't provide the service. The next time we see them is when they're in crisis. So there is a real concern about the ongoing structure of Medicaid managed care, both in terms of the rate of compensation and the framework for compensation, and the impact of the MCOs functioning less as innovators than as gatekeepers, and getting compensated on time. For the rural CSBs in particular, there's a high dependence on Medicaid to make their budget. That's where they make their money, and when it's costing you more to provide the service than you're getting compensated, that's going to result in a fiscal crisis. So that is the concern that they have. There is commitment to the structures, the concepts behind STEP Virginia and the development of the DLA 20 as a framework for the performance contract. The question is, because so much money, as you know, a good deal of that money, the state general funds, is being moved, it's being taken away from CSBs because more people are going to be covered by Medicaid managed care. So the framework for compensation changes. That's not in the performance contract. So that is a big concern from the CSBs, that they're going to have real difficulty being able to effectively provide services to the community, to people in the community, to keep them well. I'd also point out that they are responsible, CSBs are responsible, only about 1/3 of all Medicaid mental health dollars that are spent. So you've got lots of other providers out there. If they fail, their client, if there's a problem there, the CSB is the one who has to pick up the crisis. So the other is providing community-based alternatives to the hospital. And approximately 55% of psychiatric pre-admission screenings occurred in emergency departments. According to a survey in 2016, the emergency department, as emergency department directors will tell you, is not a good place for people in mental health crisis to be. And so there was widespread view of the importance of helping to address people in crisis as early as possible. And we talked about a number of different possibilities and services were identified. One is the mobile crisis unit. In your appendix is a proposal from Blue Ridge Behavioral Health for a mobile crisis unit that would also include psychiatric consultation, prescription of medication. A survey that was done a few years ago indicated one of the things, availability of medication in a crisis was also seen by evaluators as being a critically missing piece. So this proposed pilot project from Blue Ridge would incorporate that, and they would also use the psychiatrist services to help with the same-day access. If there's someone who's a walk-in who needs services, that psychiatrist would be available for that. So that's one model. The second is the Peer Respite Center. There are not specific proposals for that, but that the peer recovery centers are walk-in centers that would be located in community settings to be available for people early on in their crisis to come in and get supportive care with peer operated setting that would be welcoming. Psychiatric emergency centers is a third. I've been talking about this for about 3 years, and this model, there are different variations on this model, and you've seen there are three different ones in the proposals. One from Region 3B, one from New River Valley, and another from Region 4, which Region 2 considers to be an excellent model they would like to look at. And they all share a commitment to what's called the living room model, use of peers, providing a comfortable, welcoming environment, de-escalation, engagement in all the facilities with clinical staff, and the opportunity to help the person stabilize without their further deterioration. As you know, the hospital ED is a place where a lot of people go from bad to worse. And so the concept here is a psychiatric emergency center would be a place, an alternative, where individuals could get early involvement and assessment and the possibility of resolving the crisis. If it was not possible to resolve the crisis, then certainly we go to the next step. And the PEC is also geared to address that. The Psychiatric Emergency Center is essentially, for the most part, a 24-hour center. In other words, a person would stay a maximum of 24 hours, would be outpatient. I would note the facility in New River Valley varies a little bit from the others, but it still has the model of allowing people to come in and get settled and stabilized. And what's interesting about theirs, as well as Region 3B, is that they would co-locate with their existing Crisis Intervention Treatment Assessment Center, and New River Valley has a crisis stabilization unit with detox and capability for TDO that's only 10 minutes away. So the idea is to help people resolve their crises locally, to stay home, and in the least restrictive setting. If the PEC model were to be used, and I would note that it has established efficacy in a number of states now. The folks in Region 4 visited one operated by Recovery International, and they saw a facility in Delaware. And it does have established efficacy. What we would want is if it were possible to set up some of these as pilots, that the legislation would be changed to allow for the ECO to be 24 hours. Once they enter in, if a person's reached the stage where they have to be taken into custody, they're under the ECO, then the PEC, if they enter there, they would have 24 hours to help that person and see if they could achieve stability. And we certainly have evidence that there's a significant percentage of folks who would benefit from that. 20 to 25% of the voluntary commitment cases are dismissed because the person no longer meets criteria. And usually that recovery in an appropriate environment can occur in a different setting than a psychiatric hospital. I do commitment hearings. Any number of folks that I've met with, by the time I see them the day before, they've been in there 24 hours too long and they want out. So this is an important missing piece in the continuum. I would note in our last task force meeting, there was a discussion, we learned for the first time there's work being done between private hospitals and DBHDS to discuss the possibility of establishing observation units in the hospital so that individuals could be escorted if they're in a mental health crisis to a separate calming setting away from the hospital ED and into a different environment where there'd be some access to other services and support instead of the person simply being in custodial care, which often happens in the hospital ED. We do not have any specifics on that, but that is, we see that as a very productive conversation and an important commitment by some of our private hospitals.
John, excuse me, Delegate Ranson has a question.
Mr.
Yes.
Chairman, your suggestion to amend that extension, would you suggest that for the folks that are going in under voluntary ECO as well as the ones that are mandatory ECO? Is that what you're suggesting?
I would recommend anyone who's under an emergency custody order because it's, they've reached an emergency custody order is basically based upon a finding that the person appears to need hospitalization. Their deterioration has reached that point, and that they're not at a stage where they can make decisions on their own and manage, so that they clearly would need some time and get a fuller assessment. Part of the difficulty for evaluators is that they're often seeing people in the height of their crisis, and sometimes that's fueled by drugs or alcohol. Another few hours can really make a major difference in their clinical presentation and also in the needs that they have. And frankly, in self-harm cases, big concern I've had with people in self-harm is their attorney. So I see their cases dismissed, and they're gone. That's it. Case dismissed,
Okay.
and it's closed. And this provides an opportunity for some real engagement and helping people.
Mr. Chair,
Senator Dees.
but you recognize that any extension of that ECO period is going to involve, we're going to have to make some decisions about who's going to provide security for that.
Yes, sir.
During that
Well,
period,
and
because in a
I
lot of
would
our
note-
rural communities, sheriffs tell us all the time that the security they have to provide, the travel they have to provide is untenable, it's
Right.
expensive.
Well, here's the key. They would actually be more local. The second is all the PEC proposals involve having on-site security. And so they would, just like with the CTAC, an officer is bringing someone in would hand the person over to someone with that authority. Over in New River Valley, it's actually co-located with the CTAC. So there is not going to be the same kind of issue.
So, Mr. Chair,
Senator Dees.
your recommendation with respect to a PEC right now would just be on a pilot project basis? Just to one of these facility places where they already have one?
Well, where they're being proposed to have them.
Yeah.
We would ask that you look at them. Each of them has a different inflection that reflects their regional character. And I think that each of them brings real value to the table. New River Valley's got all their numbers, and it's there in the proposal. And again, the extension of the ECO would be tailored to that, would be limited to that circumstance, PEC. Probably taking too much.
Okay, go right ahead, John.
All right,
We
sir.
gotta-
And the other key thing we are looking at is finding ways to ease the transition or make it easier to transition patients from the hospital ED to less restrictive care. Part of what we heard in some of the meetings was that it can be difficult, oftentimes simply because of staffing issues at some of the crisis stabilization units, to get a timely transfer of people from a hospital setting to a less restrictive setting. So that's part of what we want to work on to take a look at ways to make it easier for people to make the transition to CSUs and to other community placements to transition back home. The other key challenge here, as I mentioned earlier, is developing community placements for hard-to-discharge patients. We did have in particular, Region 2, we had a meeting, and the private hospitals noted that one of their concerns about accepting folks with serious mental illness, with chronic conditions and difficulty in treatment is being able to discharge them. And they noted that they had any number of folks who had been in their psychiatric unit for months because they couldn't find a place. Now, the Region 2 coordinator checked with both Northern Virginia Mental Health Institute and Piedmont to look at the level of need of the individuals on their extraordinary barriers list. And at Northern Virginia, 24 of those 34 individuals required 24/7 supervision, needed a high level of care. And so they have, Region 2 has a specific recommendation for developing two programs, one in ALF and the other an intensive care plus facility with a high level of staff to patient ratio for care. These are people who can be managed outside the hospital setting, but their level of need is so high that they need a facility like this. I know that the committee and the department are committed to permanent supportive housing and as integrated a setting as possible, but there are going to be some circumstances where the level of need of individuals is such that you need a facility like this. So that proposal is also in your package. I would note the growing challenges here, even if we address those things, we have people who present specific and difficult challenges. In particular, I would note the ID-DD population. While the number of folks in the state hospitals who have ID-DD is in the single digits, approaching 10%, the percentage at CCCA is 29%. And that's the future, unless we do something to develop programs, community-based programs that are more specifically addressed to crisis for individuals with ID-DD. There is a proposal that came in Region 4 for a dedicated hospital unit south side to help to address the needs of people in crisis with ID-DD, but don't know the status of that so far. That is something that they'd like to pursue, but I think community-based Project REACH has been very vital, very important to communities, and is an important service, but we're still having increasing rates of hospitalization of individuals with ID and DD, and their crisis and the way they respond to treatment is fundamentally different from people with schizophrenia or depression or in a different sort of psychosis. Then other key populations are those with dementia, frequent utilizers, people who regularly turn up, and then we have to develop more community-based programs to intensively case manage those situations, and then individuals with aggression. And so we just note that while there were not specific proposals on that, those are populations we have to be addressing down the road, or we're going to continue to experience this crisis.
Mr. Chair.
And then finally, as we've discussed already,
I was just thinking about another special population. We stay full at the CCH hospital in Stanton, and we just toured the hospital in Richmond this morning. All our juvenile beds that are available full too. Do we have a crisis with children who in the TDO go through the TDO process?
I'm sorry.
Are we at crisis with young people in the TDO process?
Answer is yes.
And how do we address that?
Yes, and I confess, and I've made the confession, we've not adequately addressed that at this point. Most of the discussion is focused on the adult population, and you're absolutely right. Children's needs have not been adequately addressed at this point.
Okay. I think you're getting ready to wrap up there.
And I would note, we've already discussed those with complex medical needs. There is a specific proposal that's included in the report regarding the state hospitals would like to be on the same footing as the private hospitals when that ECO period runs and the first 8 hours runs and a placement can't be found for a person with complex medical needs. That's in discussion right now in our task force, see if we can find a way forward. But the concern is as long as it's known that, if we say no, the folks who go off to a state hospital, then there's not a lot that pushes you to have to come up with solutions for a very difficult patient. And I think, again, we're back to compensation because these are expensive patients to treat too.
Okay. Other questions here? You've presented us with a very thorough outline of the issues, and I know there are people in the audience that probably have answers to a lot of the questions you posed or we posed. So we'll have to continue the conversation. And
yes, sir.
You do intend to make some recommendations?
Yes, sir. We'll have a follow-up meeting in the task force.
Great.
So our thought was that we would present this today, but we'll have recommendations for you in December.
Great. All right. Busy December. Thank you all so much. Okay, our final presentation is from the Department of Behavioral Health. Connie Cochran here today, the Acting Deputy Commissioner, to report on building system accountability.
Good morning.
Good morning.
Most of you know me as Mr. Chairman in a different role as the Deputy Commissioner for Developmental Services. August 24th, I stepped over temporarily, temp job, to set up the division with administrative supports. We're actually doing interviews this week, so I'll be stepping back to my old job shortly, hopefully. I'm going to step through this fairly quickly. Going up to full screen. Thank you. So hopefully I do this the correct way. So basically, I'm just going to touch quickly on the law. I understand you've had a couple of presentations on that. Some of the things we're doing now with oversight and some of the state-local partnership models we're looking at as we restructure the department. So just quickly here, these are the 3 sections plus the state board policy that specifically deals with performance contract. The board policy lays out what the match is considered. That area is set to 10%, how that's composed. We have a department or a board policy for that. So the process, just quickly on that, is pretty much almost a year-round process. By the time the CSBs sign the contract in the summer, we start over again, looking at the different aspects of that. The current contract is 84 pages long. I do not know it inside or out. I've read it more closely lately due to my current job. So we begin this whole process. If there's a major change to the form, which we don't anticipate this year, that would have to go out the 1st of January. Most of the changes in the past and what we're looking at now should hopefully position us for the next phase of the contract in 2021 and 22. So these are some of the things we do and monitor. So we've really focused on looking at these aspects of this. We are trying to work on improving databases and the data that we pull from that. We do look at the audits that are reported. The internal audit team goes out and over the past few years, they visit at least 5 CSBs. They start that in October. The first CSB this quarter was Eastern Shore. They just finished their on-site visit up on Friday for doing that. So part of what we're looking at is the data, and it was mentioned earlier in earlier presentations, the importance of data. We have doing a lot to align our data collection and how we are putting that together. And then some later slides, I'll show you some of the things we're doing with dashboards. We just put out new dashboards this year for some of the data. And this is some of the changes over the past few years. And you've heard REACH referred to. REACH is one of the few programs that the states has ever developed that was based upon an evidence-based model and was put out statewide and statewide standards. And you'll see that referred to some of the regional things we're looking at. And so a lot of the changes have been related to the settlement agreement or other funds that have gone out to the CSBs. The FY19 contract is a lot more changes going on. The first one is to re-engage folks who had been engaged with the CSBs, beginning to establish same-day access. The Commissioner, I believe this afternoon, will touch base on the definition of those other things that are being refined. So also the mediation process. We just put out, changed some of the 7 performance measures with different benchmarks. We went through a long process with the CSBs to define those with our subject matter experts. This year did increase the financial reserves that CSBs must maintain, and so we're tracking that, and then the tracking with discharge and admission from the hospitals.
Yes, Dr. Garrett.
So Connie, thank you.
Uh-huh.
Because that's actually the first time that I've been here in 9 years in Richmond that I've actually seen delineated some objective metrics that now DBHDS is going to be going forward,
Right.
requiring through a contractual relationship each of these 40 CSBs to perform.
Right.
Do you intend to collate all of that and be able to get back to the General Assembly the performance standards, meeting those standards, not meeting those standards for each, not in the aggregate, but for each one of them, so that we can begin, as Senator Barker just said, we may need more resources in certain areas that simply don't have the local resources and capacity, and allow those that do have greater capacity to be able to do what they want to do locally. Is your intent that you all will get us that data by each of the 40, not aggregated totally, but by each of those 40? And if so, because you're nodding your head, when do you expect that report to be available to this young surgeon?
You're asking me to jump ahead. I may have to get a lifeline from some folks in the audience from the department. We have put together those dashboards where the data went out just a few weeks ago or a couple of months, maybe a month ago. Also, the changes in CC3. CC3 is a somewhat difficult database to use, but our data warehouse and analytical people have designed the data that we can measure and publish those dashboards. So my answer is we should easily be able to do that, or should be doing it. I just don't know when that will first come out. Some of the data reports that are coming in are a little bit late due to some of our not getting it out early enough, but they are catching up. We haven't done the annual report, so that's a question we can follow up on. I don't know if Daniel has an idea of the date. Yeah. So, but as soon as those come together, we have a much more capacity to do that than we did in the past. So we'll do it as soon as possible.
And I appreciate that more than you know, Mr. Cochran. So, I mean, do you think you'll have that data in 3 months, 6 months, a year from now, several years? How long would it take to get roughly-ish? I won't hold you to a specific
Well, I mean,
date.
I think there are two points there. Is you collect the data and you look at the benchmarks and see what they are, and then you adjust the benchmarks. I think that's a multi-year process. But we are collecting the data, and we will see that. We've been collecting data on enhanced case management. We've been collecting a lot of this data, so we have that. I just don't think it's going to be that long. That was a question we can check back at, and the Commissioner can answer this afternoon.
Awesome. Thank you very much,
Okay.
Mr. Chairman.
So part of this is also we recognized in looking at a next generation performance contract that's much more outcome-based, that we needed to look at our, not only the authority, but how we would reorganize the organization to support that. Some looking at performance changes, and then you've already heard about the measures, and then some focus on some increased regional collaboration. And I'll go through those quickly. This is the code dealing with some of the performance contract. We mentioned that earlier. The infrastructure is on August 24th when the commissioner finished working with the senior management to redesign the structure of the department. We recognized that we needed to design our structure to sort of align with where we thought or see the community services are going. So part of that is we consolidated all our IT and operations under the new deputy administrator. We've been putting that together so that all that data and financial information flows together. We also created within that division an Office of Management Services. We've just finished doing interviews for a person to be hired for that with more project management skills. We did an internal focus group with our staff in looking at how to manage the performance contract going forward, much more broadly across the organization as everyone in the organization is really linked to the performance contract. It's going to have a more of a coordinating role. And then have the ability to adapt that and provide the expertise for doing that. So it's a much more project-based management style for that. And then we've also transitioned temporarily all the former responsibilities of the former office that faded out in the last 2 months. And then we will be going, I'll show in a later slide of where we see the timeline of getting to the first generation performance, a more value-based purchase contract. This slide sort of gives you an idea of where we see that the elements of getting to that. Moving from a contract that's been basically paying for a lot of transactional activities and counting sometimes more of just numbers and services is really looking at how we organize our structure The technology, we put in a budget adjustment request to help streamline more of our data warehouse, update some of our activities around that, our IT systems, and how we visualize that data. And then we also, the other aspects of this. So it is a multi-year process of getting from a contract that's been fairly standardized. There are some more performance measures in that, a lot of that driven by the settlement agreement. But it is also, we recognize that we need to do some work changing that over the next 18 months. A lot of work changing that. This is the timeline that it's a rough timeline. So this year we'll be making some changes to go into 2020, but that'll be more focused on things that would support the next generation performance contract. So that's the sort of the process. We would come back next summer and start working through the administration with any code changes that may or may not be needed for that, and then launch the first generation performance contract. I say that it's the first generation because it takes some time to move from providing more risk and also what you're collecting for data. We still will have some processes in there, but more and more to give the CSBs flexibility of achieving outcomes without necessarily prescribing they do X, Y, and Z in that order. So that's where that projected to be. My slides are out of order. So I mentioned this, you heard already about using the data and building that into it. We also are in the process of finalizing revised checklists with Attorney General's Office and Department of Justice that the judge will accept in about 45 days. That checks off very clearly what the Commonwealth needs to do to exit the settlement agreement. That may change some of the things that we need to request from the CSBs to make that target date for 2021. I'm through this in here because this is an example of what I think it really takes to develop an outcome measure. One of the areas that we are short in meeting compliance for the settlement agreement is case management. So over the past almost year, we have been engaging intensively with the CSBs to develop outcomes. The former commissioner sent a little bit 8 or 9 months ago, or almost a year ago, 7 or 8 or 9 key areas we need to focus on. We provided on-site assistance with staff who looked at all the data collection and processes.
The system has detected that a minimum number of lines are connected to this conference. Do you want to continue your...
So with the 40 CSBs, they got on-site consultation, looking at their data, making sure their data was being reported correctly, scrubbing that data. We also have they've had a work group that we have helped support in looking at outcome measures. And so this is the first generation of what you would potentially see in an outcomes contract. So case management is very critical to the DD system. And then this is an example where each CSB has a dashboard. We're getting ready to publish the first generation of this one. And they can compare it to a sister agency who's similar in size, similar in population, and then look where they stand at meeting these outcomes. So this is an example. It's a process you have to really engage stakeholders with. You also have to vet your data and make sure it makes sense. So we're going to throw that one in.
And Connie, when is that available?
That one is available on Tableau right now. We are still vetting some of the numbers, but they have the ability to get that access. I don't know if we released this last one yet. This is the one I just pulled off the sample last week. But this is the data elements, and then over time, those dashboards can develop or benchmarks from that to see what's comparison. And this is where you have the ability to compare different populations. We'd expect, 2 very different CSBs that have very different outcomes, but also CSBs can also use this as a management tool to say, if we're similar in size and population served, why is our sister agency achieving this, and hopefully encourage some regional approaches to dealing with that.
Mr. Chairman, follow up? So Connie, is that going to be available to either the General Assembly and or the public, or is that just going to be used internally?
No, it's available. It'll be available for public on Tableau, public Tableau.
Oh, good. So, thank you.
You're welcome. Some of the regional collaboration, we have a meeting this week again with the CSB's leadership. So we've basically put together a straw man or idea of looking at creating some sub-regions in at least 3 regions, mainly for geographic size, and then looking at what particular service or activities from STEP Virginia or residential crisis services could go through a more regional delivery model. But this is, once again, we have tried to make limited impact on the 5 regions, and then created within those sub-regions, and then in conversations with CSBs, look to see if we need to shift those or not. We have regional staff. We only have 2 areas that have sort of a regional office. So we're also looking at where our staff are and how they can support the communities in these 8 regions. So the other one is we continue to look at the existing authority and capacity and what we need to do that. And then other state partnerships of looking at how the State Board of Education, a Board of Social Services are doing some activities in the region. And then how we have ability to influence going forward, how we support the CSBs and their board membership and leadership selections. And then the other one really is looking at, do we need to take some of the things that are in the contract, make them more of MOUs, and then what's really is like, how do you really do a corrective action plan, and how would that look going into the future? So that's questions. I know I went fast, but trying to get through it for you.
Connie, this is very good. Thank you very much. And with your dashboard, do you have a way to somehow objectively indicate relationships with each of the CSBs with their local education systems, with their local Department of Corrections, with their local law enforcement? Do you have any way of grading that?
That's a good question. I don't know if we have that yet. I mean, part of what we're doing is looking at our internal data and what the CSBs report. We have looked each region, Medicaid lives. We've looked at some other indicators. I think if the data's out there, there's probably a way we can get into our data warehouse. But.
Thank you.
Right. I think the Commissioner's going to address that this afternoon at 2:30. The Commissioner's going to address that in his presentation this afternoon. Okay?
Mr. Chairman, if I could make one follow-up comment to Delegate Garrett's question. So I can't answer Delegate Garrett, like Connie, exactly when the data would become available. But in light of the prior conversations, I just wanted to make sure that you were aware, as STEP Virginia is built out, there are performance metrics for each one of those investments. And so much like what you see on the slide that Connie showed you, we will be able at a point in time to give you that same information about STEP Virginia. We are in the process of discussing that with the CSBs. And I don't want to steal my boss's presentation. I just wanted to make sure that you were aware of that as well.
Mr. Chairman, if I may also follow up on Delegate Garrett's comment as he threw in the word schools. Through the effort of the last 6 months or so, looking at school safety issues and renewed focus on the threat assessment teams, do you have specific reporting on the degree to which CSBs participate with the threat assessment teams of schools?
I don't know that. We'd have to get that for you. So.
Thank you.
Mm-hmm.
Okay. Encouraging, I know sometimes it seems we operate as policymakers in a vacuum. Sometimes maybe we do, but we shouldn't. But it seems that some of the work that's ongoing now is kind of bubbling up potential solutions to the questions that we are posing in terms of regional control, collaboration, and things, the models that you are working on. So hopefully we can continue to work on and flesh that out. Also, it's the interconnectivity of the issues with the settlement agreement, right. Closure of training centers, and all of a sudden we've got issues with ID and DD individuals presenting themselves, which routinely years ago, not the right thing to do, but we would just put them somewhere and not right. deal with. So it's all interconnected. So thank you for the presentation, and we will certainly be interested in the follow-up sessions this afternoon. Any public comment? Any of you all sitting there that we've kind of jarred some things that y'all would like to address? Okay, Jennifer? we step all over your toes, so you ought to say something.
Good afternoon. I'll be brief. I know you all have another series of meetings coming up. Jennifer Faison, Executive Director of the Virginia Association of Community Services Boards. And I just wanted to respond to a couple of things, most specifically in the last presentation that you heard. And I think from our perspective, we are really excited to be able to move towards a performance contract that is more outcomes-based. Just as an example, if we're meeting our marks in case management, then maybe caseload size isn't an issue. So for example, if we're performing well, why do you care if we have 20 people on our caseload or 25? And so some of that kind of more intensive outcomes-based approach, I think, would be very good for our system. We are concerned a little bit about the timeline that the department has put out for that. If you look at the slides, specifically related, like slide 13, for example, an updated outcomes-driven performance contract will rely on data from the DLA 20. So we're implementing that in January of 2019, but it will be for the existing clients in the CSB, we're going to have to fold them in. So for new clients coming in, they'll all be using the same instrument, all the CSBs, and they'll be using that instrument on people quarterly. For the existing clients in the CSP, they're going to have to go back and pick them up, and those will be at their annual review. So you won't have a full year of data until January of 2020, and you won't even have a full 2 quarters or 3 quarters of data on all of the individuals until sometime after that. So to suggest that the performance contract based on DLA 20 data is feasible, you would be basing the contract on an incomplete set of data. So we would have some concerns about that. The other thing is that the DLA 20, it's daily living activities is what DLA stands for, and that's really not a sensitive enough tool to measure things like clinical outcomes associated with outpatient services and those kinds of things. So we would have concerns about that as well. I might also draw your attention to slide 14. The department has been incredibly supportive in making sure that we have some way of looking at our own data. This is specific to the DD community. This dashboard is based on current CCS3 reporting, so this isn't new. This is something that we've had access to. It's just a different way of looking at it. So I wanted to make sure that you all understood perhaps really the outcomes-based part of this is maybe only related to like assist level. That's not an outcome measure. Waiver distribution, not really an outcome measure. So this is more of a data visualization tool, and I think it's a first step in that direction, but it doesn't necessarily speak to outcomes per se. As far as that's not how we understood the tool. And then I guess lastly on slide 15, engaging the 40 CSBs, Connie mentioned that the department had put forth a straw man. So we received information from the department about how they would like to organize the CSBs into subregions, and we have some concerns about that, not necessarily with the general concept, but the framework which has been laid out to date does not give our CSBs enough information in order to decide or to engage in conversations about what that might actually look like. And in fact, we would be very concerned that the way it's been laid out would create winners and losers within a region with regard to distribution of funds and some administrative support that you wouldn't be able to untie. So I would just say, we are going to continue to engage the department in those conversations, but we're not, it's not ready for prime time as far as we believe.
Okay, Mr. Chairman. Dr. Garrett?
Jennifer, thank you. I assume you all, boots on the ground, worked with the department on these 7 performance measures with definitions, benchmarks, and monitoring language. Do you all have other performance measures that in the industry you all believe we should be following to actually come at better outcomes?
Are you referring to slide 7 when it talks about the 2019
Yes, ma'am.
performance contract?
Yes.
The performance contract, again, as Connie mentioned, is a negotiation between the CSPs and the department. And so I think that we generally would use that opportunity to kind of look for metrics and outcomes that we would want to put forward to the department. I think the DLA 20 is going to be very, very helpful in terms of if you think about the same-day access process, all of the CSBs got a consultation with that. And what the part of that consultation did was to allow the CSBs to understand what it is costing them to deliver the services as well. So what you get when you combine the DLA 20 with that kind of cost measure is the ability to say, okay, within a CSB, either for our folks as John Oliver mentioned, sometimes maintenance is success. If they're not having increasing psychiatric episodes, if they're maintained in the community, that's success, or improving. So if we all agree that improvement or maintenance for a certain percentage of that population is the goal, and then you look at the amount of money it's costing a particular CSB to meet that, to make sure that a certain percentage are maintaining or improving, then what you get is an idea of relative to other CSBs or relative to the system as a whole, is it costing X CSB Y amount of money to provide these good outcomes? And is it costing other CSBs more or less? And what are the challenges that creates? So I think that to us is going to be very helpful and productive as we move forward, but it's not the answer to everything.
And Mr. Chairman, just to follow up. So I think I interpreted that to mean that these 7 performance measures plus the DLA 20 is a good start?
Yeah.
Is that a fair statement?
Yeah, I think
And,
so.
and then, Mr. Chairman, just as a follow-up, I
The-
think I understood you to say that you really didn't think we'd have meaningful data now for another year and a half or 2 years. It's going to be very difficult with the balancing act of all that we appropriate, it's going to be very difficult to make the case that a particular performance is addressing the needs, particularly what the General Assembly has recognized and Virginians need. It's going to be very difficult to appropriate more money for those needs if we're not going to find the answers to how we objectively measure that for another year and a half or 2 years. So I would encourage your association, your folks, to really work very hard with DBHDS and make sure that as quickly as we can get that data to the General Assembly so that we can have, very, very meaningful conversations about what that level of funding would be. It used to be just a want that we wanted to have some objective metrics. I would tell you categorically it's a need now, and that's not a political thing. It ain't a we versus they. It is the balancing act of trying to appropriate some scarce tax resources.
Mr. Chairman, if I may,
Yeah.
the DLA 20 data was the data that I was referring to. You all have a wealth of other data through the CCS3 reporting mechanisms that could be drawn upon to look towards the kind of things that you are interested in seeing. So it's just that one part that we're implementing, and it will have to roll in, and we'll be dragging a quarter or two of data behind it before it's accurate.
Thank you. Thank you.
Okay.
Sir.
Thank you, Jennifer. Jennifer, are y'all monitoring the work of the data, the new data collection guy over with that work group? Are y'all into that? Probably not. I'll talk to you about that.
Actually, we have a report coming, this should be delivered this week.
Okay.
On that, where we are on things, and we've set up the governance structure for beginning the process there.
Okay.
We've got a ways to go.
We got to tie all this together at some point. Right.
Yes.
Okay. Thank you, Jennifer.
All right. Thank you.
Margaret, do you have some comments?
Good afternoon. Thank you. I'm Margaret Nemo Holland, the Executive Director of Voices for Virginia's Children, and I will be very brief. I just wanted to thank Senator Deeds for his question about children and hospitalization and comment on John Oliver's presentation, or really sort of step off of that. I was in contact with the Commonwealth Center for Children and Adolescents about a month ago about all the work that they've done sort of in the off-season for children's hospital beds, now ramping up into their busy season. So my information is not up to the moment, and I know that the department can provide much more detail. But I do think that we have a particular crisis in the children's system, and I think that some of the issues that John Oliver highlighted cross over into the youth, but I'm not sure that all of them do, and I think the solution might be different because we're talking about families. So one of the things that stood out to me in talking to Dr. Barber about the situation with the population there is truly the IDDD autism spectrum population is really one that we need to carve out, and I would encourage you to perhaps get a presentation or look more deeply at that issue, because right now it's sort of a revolving door. So instead of having the conversation be about whether these children are in a private bed or a public bed, I think the conversation, we need to zoom out and we need to look at why these kids keep cycling. And so I think that while the REACH programs have done a lot of good work, they're not equal for children in terms of their capacity to serve youth in all regions of the state. So I think we need to look at that. And I think we need to consider the specific needs of this population. And I'm not a clinician, so you can get a much better explanation from someone who is. But the gist of it, in very general terms, is the more times that you move and transfer a child with IDDs, a child on the autism spectrum, the more disruptive it is to their behavior. And that leads to behavior that they will not be served in the private sector. So you end up having a really large and very difficult to move population in the Commonwealth Center that we don't have the services to serve them in the community, and they probably really didn't need to be hospitalized to begin with if we had some robust, intensive, community-based services for this population, because it really becomes stressors that sort of set off the behavior that then can't be handled in the situation they were in before they got to the hospital. And then you change who their caregivers are and who their therapists are for the hospital setting, and that's another disruption that takes them a really long time to adjust to. And then because we need the bed, we send them back out someplace else in the community fairly rapidly, and all of those transitions are really not part of a healing process for someone who fits that demographic. There's certain types of folks who it's, getting them in and out of the hospital is actually a really good thing because being hospitalized is traumatic, but the more transitions that we're forcing this population to make, the less healing that's happening, the less stability. So I would just encourage you to take a look at that population of children and youth in particular, because they are taking up a lot of beds for a very long time. And sometimes there are situations where a teenager is very large and his behavior or her behavior is such that it takes multiple beds offline for a particular period of time. So it may not even be that all the beds are full, but you can't put particular other children who might need to be at the Commonwealth Center next to that child. So there are a lot of issues particular to that population, and I would just encourage you to take a look at that. Thank you.
Okay. Thank you, Margaret. Okay. Additional comments?
Hi, I'm Beth Tolley. I'm a parent and a grandparent, and I can affirm everything that Margaret said, who helped me with my granddaughter, who we didn't know at the time had autism, in addition to disruptive mood dysregulation disorder and ADHD and anxiety. Everything she said is absolutely true. But I wanted to speak to the with a solution. In this presentation on the TDO crisis, I think in addition to one of the helpful things under the STEP VA, it outlines some of the services needed to reverse the trends. I would add to that, and I wanted to talk to you about this, except that I need to talk to the Children and Youth Services in DBHDS. I'm also a former DBS employee. I'm retired now in infant and toddler. I'm a big prevention person. I think we can prevent a lot of the escalation. And parent support partners who are peer recovery specialists have a huge role to play. We have lots of lived experience, and we can support other parents who are going through this. And it can help bridge some of the gaps, and it can help provide education and support to families who are going through it. So I would add this population to the STEP Virginia, and there are lots of people being trained across the state who can provide this level of support. So,
thank you very much for bringing your expertise to us. Appreciate that. Any others to make comments? Okay, seeing none, I think we've pretty well exhausted our time. It's supposed to be 20 after 12, but our stomach says 20 after 1, I think, still, right? Sarah, I think we've kind of outlined a number of issues relative to our what potentially will be recommendations, and then the plan probably, then we won't go any further with that right now. We'll have the full meeting at 2:30. Is there another meeting in between that?
Yes, work group number 2 will be meeting in this room at 12:30, and the full joint subcommittee will meet in this room at 2:30.
Okay, all right. All right, I would think it would be in order for us to adjourn then. That's what we'll do.